Okay, we can get started. Good afternoon, everyone. Thanks for joining us for today's Dana Farber Harvard Cancer Center seminar, Connect Science seminar. Just a few reminders. If you please post your questions in a Q&A function on Zoom, and we will answer as many questions as we can at the end of the presentation. And also today's presentation will be recorded, so you could go back and check it on the website as indicated on the first slide. And it's my pleasure to introduce today's speaker, Michelle Monge from Stanford University, where she's a professor of neurology and neurological sciences and also a Harvard Hughes investigator. And Michelle has completed her training at Stanford, so it looks like most of her, got her PhD in neuroscience at Stanford, and also the medical degree, and then briefly came over here to the East Coast to do residency in neurology, and then went back to Stanford for fellowship training, and she's been a faculty at Stanford since then, and now has been promoted for full professor. And Michelle really needs no introduction. She is really one of the leaders of the neuroscience, and particularly these DIPG, diffuse intrapontine gliomas field. She published numerous really outstanding papers on showing how the neural glial interactions can fuel glioma growth, and also has been really making an effort to have improvement in the treatment of the DIPG, which, as you will hear, is one of the most lethal tumors, brain tumors, and affecting children. She received numerous awards. I don't want to list all of them. She got NIH Director's Pioneer Award, and also Early Career Awards and Scholar Awards from multiple foundations, including the American Academy of Neurology, and also the AACR Team Science Award. And more recently, she got the top 10 breakthroughs in the Life Sciences Award from the Falling Walls Foundation. And today, actually, Michelle will give two talks at Dana Farber today. One of them is this Connect Science at 12 o'clock, which will be a more clinical immunotherapy talk. As you see, the title is a GD2 CAR T cell therapy for the DIPG and DMG. And then she's also talking at the 4 o'clock in a seminars in oncology, which will be a more basic research talk on the neural glial interactions. So if you have time, tune in later on also, so you can listen both presentations. So with that, Michelle, thanks for joining us, and looking forward to your presentation.
Thank you so much for the introduction, and really great to join you guys. I was now several years ago a Partners neurology resident, and it's still Boston still feels like home. And what I've done since I left neurology residency at Brigham and MGH is to focus on this really terrible family of primary brain tumors, the H3K27M mutated diffuse midline gliomas, including diffuse intrinsic pontine glioma, diffuse thalamic gliomas, and diffuse midline gliomas of the spinal cord. These are diseases that arise chiefly in children, but definitely do happen in adults, and with a pretty stark spatiotemporal incidence, such that the peak incidence of DIPG is typically in mid-childhood, around age 6 to 8, as there's actually active development, active myelination of the pons. The thalamic diffuse midline gliomas tend to happen in slightly older children, peaking in incidence around age 10, and diffuse midline gliomas of the spinal cord are most common in young adulthood and adolescence. DIPG, or the diffuse midline gliomas of the pons, are the most common of these diseases, and these are truly, the worst diagnosis we see in pediatric neuro-oncology. These are diseases that account for about half of all pediatric high-grade gliomas. They strike 200 to 400 children each year in the US. And given the median age at which these tumors occur, which is 7 years of age, this is a disease that accounts for approximately 24,000 life years lost annually in the US alone. It's the leading cause of brain tumor-related death in children, and the prognosis is abysmal, with a median survival of only 10 months. Typically, that looks something like 6 to 7 months of progression-free survival after standard radiotherapy, which is the only approved gold standard therapy, and then 2 to 3 months of post-progression survival. And part of why we are so limited in our therapeutic options for DIPG and other diffuse midline gliomas is we really, until very recently, had no way to study this disease. There were no genetic mouse models, no patient-derived resources, no cell cultures, no xenograft models, and that began to change as patients began to donate their tumors, often at the time of death. A little boy that I took care of as a pediatric neuro-oncology fellow at Stanford just after finishing my residency in Boston, donated his brain in the early hours after his passing. And from that, we were able to make the very first cell culture and xenograft mouse model of DIPG. And it's through similar such tissue donations at death, and more recently through stereotactic biopsy, that the field has begun to move forward and to identify potential new therapies. And one thing that we did with these really incredibly valuable resources in my laboratory a number of years ago, led by a brilliant then MD PhD student in my lab, now actually MGH neuropathology resident and postdoctoral fellow with Mario Suva, named Chris Mount, was to screen the surface of DIPG cells to try to identify potential targets for immunotherapy. And really surprisingly to us, what we found was just extraordinarily high uniform expression of the diacylganglioside GD2. And so this was really unexpected. Again, GD2 is a sugar. And so, we didn't predict it by gene expression changes, but actually when we look back and we look at the genes that are dysregulated by the histone mutation, we find that the GD2 synthesis genes are starkly elevated in the context of the epigenetic dysregulation that this histone mutation causes. And when we compare GD2 expression in DIPG, shown here in red, to, for example, neuroblastoma patient-derived cells, for which GD2 was identified as an immunotherapeutic target a number of years ago, we see that DIPG actually has even higher expression than neuroblastoma. And that expression is very consistently present at very high levels in the vast majority, if not all, of the cells in the tumor, in any tumor that has the histone mutation. So this is important to know, because 20% of DIPG tumors don't actually have that histone mutation, and 50% of thalamic tumors. So it's important that we have a tissue diagnosis to know whether GD2 would be a reasonable immunotherapeutic target. The histone wild type tumors do not express GD2 at abnormally high levels. And this was a particularly exciting discovery, because at the time that we found this on DIPG cells through the cell surface unbiased screen, Crystal Makel, who's really a pioneer in CAR T cell, or chimeric antigen receptor T cell therapy, had just moved to Stanford, and she had just optimized a GD2 CAR T cell for neuroblastoma and other solid malignancies. So I think I walked over to Crystal's office with this particular fax plot in hand and knocked on her door, and we've been collaborating ever since. And so Crystal at the time had this wonderful then postdoctoral fellow, Robbie Meisner, in her laboratory. And Robbie's now an independent investigator and continued very close collaborator. And so what Chris Mount and Robbie Meisner did was to put the Makel Lab CAR T cells into our patient-derived DIPG mouse models. And what we found when they did that was that over the first couple of weeks, each row here is the days after infusion of IV CAR T cells into these xenografted mouse models, we find that the pontine xenografts just kind of disappear by in vivo bioluminescent imaging. And this is in contrast to mice that were treated with a control CAR T cell, the CD19 targeting CAR T cell that is, has been so transformative for acute lymphoblastic leukemia and other hematological malignancies, should have no activity in DIPG, and we find that it does not. Though in those control mice, the tumors just increase over time. Now, having worked with these mouse models for about 10 years, I actually had never seen tumors completely disappear like this, and I thought something might have gone technically wrong, so I made them repeat this many, many times. But again and again, what we saw was tumor clearance very consistently between about 7 and 14 days after IV administration in this mouse model. When we look at the CAR T cells as they traffic into the tumor, in this image, the purple or magenta shows you CAR T cells. There's this GFP positive green patient-derived DIPG here in the brainstem. We see that the CAR T cells arrive in the meningeal vasculature around 7 days after treatment. And by 14 days after treatment, the CAR T cells have infiltrated the tissue, and these GFP positive tumor cells are gone. When we look at tumor burden at the end of the experiment, in contrast to the, here purple is the histone, it's a specific antibody against the histone mutation, so it's nuclear staining for the tumor, and green is GFP expressed by the patient-derived tumor cells. You see that these green and purple tumor cells present in the control-treated mice are largely eradicated from those that receive GD2 CAR T cell therapy. And that the mice who survive the therapy appear to be cured. Now, it's really important to note that not all mice survive the therapy. And the reason for this is that the mice that, most of the mice, and certainly the mice that died, developed hydrocephalus. And that's something that happens very commonly in DIPG anyway, because of the neuroanatomical location of the tumor in this already expanded brainstem. Any inflammation, therapeutic inflammation-induced increase in edema is going to compress the ventricular system at the level of the fourth ventricle or the cerebral aqueduct, and then cause hydrocephalus. And so as we work to prepare for the clinical trial that I'm going to tell you about, risk of hydrocephalus and mitigating risk of hydrocephalus was very, very much on our minds. What we did not see was any evidence of off-tumor on-target toxicity. We didn't see inflammation or cellular loss in normal tissues, and that's been true on the clinical trial as well. Looking at patient-derived models of other H3K27M mutant diffuse midline gliomas like spinal cord glioma, we see that there's similarly clearance over time of this patient-derived spinal cord glioma. And similarly, we see that there's clearance of thalamic glioma, an H3K27M mutant thalamic glioma, but all of the mice died in this experiment. And all of the mice died because of hydrocephalus, because the thalamus is just such an incredibly dangerous location to have inflammation, to have any kind of tissue expansion, because the third ventricle is sitting right between the thalami. These tumors are typically bithalamic. The thalami are already expanded, and so you can easily compress the third ventricle. That can cause hydrocephalus, and the tumor is sitting right above the tentorium cerebelli and the tentorial notch, and it's extraordinarily easy to cause transtentorial herniation syndromes. And so when we decided to translate this, until we had a sense of how to manage therapeutic inflammation-induced edema, we have excluded thalamic location tumors from the trial. But moving forward to clinical trial, was really attractive because this is a really interesting, the immunotherapeutic target for this lethal disease. The consistently high expression of GD2 makes it a very promising target. It's consistently high in mutant tumors and in essentially every cell, because its expression is driven by the histone mutation that is pathognomonic for this disease. The efficacy in the preclinical models was more promising than I'd seen for any other therapeutic intervention. So that was really quite exciting. It's always easier to treat a mouse than to treat a child. But we have to start somewhere, and the mice, showed this really promising efficacy. But we had to do this very carefully, because inducing tumor-associated inflammation in these midline brain regions is really a neurocritical care situation. We had to be extraordinarily careful to keep kids in-house, often in the ICU, with very careful monitoring and management. And so we opened the phase 1 clinical trial after, multidisciplinary input from neurosurgery and neurocritical care, neurology, oncology. And we opened this just at the beginning of the pandemic in June of 2020. So that's a particular challenge, as many people in the audience probably know. Clinical research has been very, very difficult during the time of the pandemic. We were able to get this open and started enrolling now almost 2 years ago. And just to introduce, this has been very much a team effort, including, Robbie Majner, Crystal Makel, Sonia Partap, Cynthia Campen, Paul Fisher on the pediatric neuro-oncology side of things, Kara Davis, Leora Schultz, Sneha Ramakrishna, Becky Richards, and others on the pediatric oncology side. And the way that we designed the initial arm of the trial, Arm A, was an IV administration dose escalation trial. And with the option to give subsequent doses if patients had a good response to the first one. So the way that the trial, this is sort of the schematic of the trial, patients have to have tissue diagnosis of the histone mutation because again, the antigen is only expressed in H3K27M mutant tumors. After enrollment and we perform apheresis and start to make the CAR T cells. During the time of CAR T cell manufacturing, patients have an Ommaya placed. An Ommaya catheter is, as probably almost everybody in the audience knows, is this little plastic reservoir that goes right underneath the scalp with a small tube that goes into the lateral ventricle. And the Ommaya reservoir was placed for many reasons, the most important of which was for intracranial pressure monitoring and the ability to immediately treat hydrocephalus should it develop. So through the Ommaya, we, with just a butterfly needle, can access and measure the intracranial pressure. We can then also take off CSF in the case of hydrocephalus and actually for a number of days treat hydrocephalus with continuous drainage through a butterfly needle in the Ommaya if need be without having to place an external ventricular drain. So very, very quick way to address potential hydrocephalus, which we felt we were at very high risk for. It also then gives us a window into the CSF where we can do, deep correlative studies, testing CSF cytokines and chemokines, testing, doing single cell sequencing on the cells that are present in the CSF. And as an additional benefit, it allows us to give the CAR T cells administered through the Ommaya intracerebroventricularly for subsequent doses. At the time that we started the trial, we didn't know how important that would become, and it was really kind of a third reason for placing the Ommaya. On this first arm of the trial, then after the CAR T cells are made, children and young adults receive lymphodepleting chemotherapy with cyclophosphamide and fludarabine for 3 days from day -4 to day -2. There's then 1 day of rest. And then on day 0, we infuse the CAR T cells intravenously. At 2 different dose levels. The first dose level was 1 million cells per kilogram, and the second dose level was 3 million cells per kilogram of patient body weight. We then monitored kids and young adults for a month inpatient with daily, careful neurological exams while they were inpatient, at least twice weekly neurological exams towards the end of that month if they were discharged, routine measurements of intracranial pressure, and at the time that we began the trial, we were doing weekly MRIs. If there's evidence of radiographic and/or clinical benefit, there was an option written in for subsequent doses given either intracerebroventricularly or IV. And what we're monitoring for in this kind of intensive, keep everybody in the hospital and watch them closely context is number 1, a complication of all CAR T cell therapy, cytokine release syndrome. We were monitoring for a frequent complication of CAR T cell therapy for hematological malignancies, actually something that we have not seen much of, which is immune effector cell acute neurotoxicity syndrome. And then really importantly and specific to CAR T cell therapy or immunotherapy in general for central nervous system malignancies, tumor inflammation associated neurotoxicity, or TN, which is a newly described entity that we're working collaboratively with the rest of the field to develop a grading scale for. This takes 2 flavors, but it's so important for CNS immunotherapy. The first type of TN has to do with mechanical space limitations. Inflammation-induced edema can cause increased intracranial pressure, it can obstruct CSF flow, it can induce tissue shifts, and even herniation syndromes. This is an emergency and may require, really intensive neurocritical care management. The other kind of tumor inflammation-associated neural toxicity is more electrical in nature and reflects neural circuit dysfunction attributable to inflammation in the place where the tumor is. This is typically transient. It is typically looks like a worsening of pre-existing deficits. Somebody who has a facial droop, that facial droop might be worse, for a week or so while there's really active inflammation in that area, and then typically resolves and gets better. We can also see new deficits. If a tumor is in a neuroanatomical location that was previously asymptomatic, we may see the symptoms attributable to that location because of the inflammation kind of decompensating that circuit function. This can be just sort of monitored. And so as you're treating these patients, especially with brainstem disease, it's really important to identify, is that new third nerve palsy because you have brainstem inflammation, in the midbrain near the third nerve nucleus, or is it because there's an impending herniation syndrome? And the input of neurology and neurocritical care is really very important to distinguish between those two possibilities. So as I mentioned, this Ommaya catheter has been really critical for both safety management as well as therapy. And as I mentioned, it allows for intracranial pressure monitoring, management of hydrocephalus, monitoring of the CAR T cells, trafficking to brain, the inflammatory molecules present in the CNS. And as I'll tell you about, and as we started to use very frequently, we can use the Ommaya to administer additional doses of CAR T cells. So I want to tell you about our experience on the trial to date. And I'll start with the first 4 patients treated on dose level 1. Then I'll tell you about our experience ongoing experience on dose level 2 and some important future directions based on what we've learned. But let's focus on dose level 1, in some detail. These were the first kids with diffuse intrinsic pontine glioma to be treated with CAR T cell therapy. This was really quite terrifying. We really did not know what we were going to find. The very first patient is the patient on this dose level who actually gleaned the least benefit. She was treated at the time of early disease progression. We saw stable disease at 1 month and then rapid progression. And I'll go through each of these cases in detail, but first just want to give you an overview. The second patient was a young man who was treated also at the time of early disease progression. He had radiographic and clinical improvement at 1 month after CAR T cell infusion. He was stable at 2 months, but then began to progress again at 3 months. And as I'll describe, we treated him again. The third patient was a young girl who was treated prior to clinical and radiographic progression. She had both radiographic and pretty marked clinical improvement at 1 month, which also continued through 2 months, but with disease progression at 3 months. And the fourth patient was a young woman with a spinal cord diffuse midline glioma. Unfortunately, she developed rapid tumor progression while we were making the CAR T cells, and we had to take her off trial and treat her on a compassionate use basis. She exhibited a marked therapeutic response in her spinal cord tumor, but not in an area of brain metastasis. We saw that all 4 subjects had cytokine release syndrome very predictably between days 6 to 7 after IV administration. One of the 3 subjects treated for DIPG exhibited tumor inflammation-associated neurotoxicity that required neurointensive care management. There were no DLTs on dose level 1, and 3 of the 4 subjects experienced meaningful, although transient, clinical improvement. We retreated 3 of the 4 subjects with a second dose of CAR T cells, and we gave that intracerebroventricularly. So let me tell you about each of these first 4 patients. The first patient was a 14-year-old female. She had a 1-year history of DIPG. She had been treated with radiation therapy and panobinostat. We gave her 1 million CAR T cells per kilogram of body weight intravenously on day 0. By day 2 to 3, she started to exhibit a worsening of her pre-existing neurological symptoms. As our first patient, we transferred her to the PICU for closer monitoring. And I just want to point out that her tumor was quite dense and quite large at the time of treatment, with very little CSF flow around the brainstem and already some degree of effacement of the fourth ventricle. Day 6 to 7, she developed a fever, so grade 1 CRS, together with increased brainstem signs. She had new vertical nystagmus, a new facial droop attributable to the location of her tumor. When we did an MRI scan, we saw that there was increased edema in the tumor. Given that this was the first patient, we gave her dexamethasone and tocilizumab because we were worried about worsening of the cytokine release syndrome. Tocilizumab is an anti-interleukin 6 agent, but it does not enter the CNS. On day 9, she had this terrifying acute episode of hypertension, tachycardia, an acute change in mental status with sudden somnolence, and began extensor posturing in both upper extremities. She also had a new right hemiparesis. We quickly measured her ICP through the Ommaya catheter and found that her intracranial pressure was elevated at 22. We took out 6 cc's of CSF, which decreased the ICP to 16, and she immediately woke up, started moving her right side again normally, and stopped posturing. We gave her a high dose of dexamethasone, and we started anakinra, which is an anti-interleukin 1 receptor agent that we have found to be extraordinarily useful in managing this tumor inflammation-associated neurotoxicity. It's now something we use very early in the course. Unfortunately, we were unable to wean steroids completely. We were able to wean anakinra, but she just continued to progress and passed away from her tumor 3 months after infusion. At the time of her death, she donated her brain, and we found that this is a tumor that is typically pretty immune cold. There are almost no lymphocytes at baseline in most DIPGs. We saw a large number of lymphocytes within her tumor, not in normal, not tumor-affected brain. Doing in situs, we found that many of these intratumoral lymphocytes were indeed GD2 targeting CAR T cells. We did not see CAR T cells in her normal brain. We still had antigen. She had high GD2 expression levels in the tumor. Just to show you the differential, there's very high GD2 levels in DIPG tumors and pretty low but present levels in normal brain. Again, we've seen no evidence of off-tumor on-target toxicity. We've seen no evidence of the T cells attacking normal brain. They seem to need this very high antigen density, but it's always something we worry about. In the tumor, we saw, as one often does, regions of the mass that had, very, very high myeloid cell content, shown here in green, many, many microglia, macrophages, other myeloid cells in areas, particularly where the tumor was the densest. The second patient was a 21-year-old male at the time that we met him. He had been diagnosed 1 year previously. He had been treated with standard radiation and ONC201. He was in early clinical and radiographic progression at the time of trial enrollment, and also received 1 million cells per kilogram IV. He had grade 1 CRS. He had a high fever, but that was all, and tolerated this very well, and had really marked improvement of his neurological symptoms and signs. His neurological exam resolved to being nearly normal over the course of that month. His tumor reduced moderately. This is what the tumor looked like at baseline. Here's the tumor at week 4, but his clinical improvement was really impressive. So he went home for the holidays and was doing great for a couple of months. And then around month 3, again, we really did not know at the time how long, a response might last or whether repeated administrations might be useful. Around month 3, he started to clinically and radiographically progress. He exhibited worsening of many brainstem symptoms. He had developed a worse left 5th, 6th, 7th, and 8th nerve palsies. He developed right hemiparesis, right hemisensory loss, and an ataxic gait. He came to us and received 30 million CAR T cells through the Ommaya catheter intrasuperventricularly without subsequent lymphodepleting chemotherapy. On really that same night and into the second day, he developed fever, headache, nuchal rigidity, nausea, vomiting. His intracranial pressures were normal until late in the day on the second day after intrasuperventricular administration. When in the context of continued fever and headache, he became suddenly somnolent, developed a new third nerve palsy, and his intracranial pressure when we measured it was 34. We immediately drained CSF and he woke up and improved clinically. His head CT was consistent with obstructive hydrocephalus due to the pontine tumor edema. We left that Ommaya accessed. We treated him with dexamethasone for, we were able to wean off the dexamethasone by 4 days after starting it. So day 6 after infusion. He was able to transfer to the floor and we were able to discharge him by day 11. And he had marked improvement clinically, as well as radiographic shrinkage by about 25% of the total tumor volume. Here's his tumor at the baseline, down in the lower brainstem in the medulla. At the time of the second infusion, 2 weeks later, it had decreased. His cranial neuropathies markedly improved, as did his functional status. When he came to us, he came for the second infusion in a wheelchair. He was unable to walk for long distances because of markedly ataxic gait. This is what his gait looked like prior to infusion. You see that it's quite wide-based. He has a right-sided spastic hemiparesis with right leg circumduction, decreased right arm swing. He's trying to walk on his toes now, which accentuates both the hemiparesis and the ataxia. He'll turn around multiple steps and he'll attempt now to tandem walk, but he's unable to, and actually we have to catch him. 2 weeks after infusion, this is his gait in clinic. It's much faster, much more narrow-based. He turns, with 2 steps. There's still a little bit of decreased arm swing on the right and a little bit of right circumduction, but just dramatically better. And he actually left this clinic visit and went for a 2-mile hike with his family and a day trip to Napa. So really, really dramatic clinical improvement. The third patient was a 5-year-old girl with a DIPG that had responded fairly well to radiation in terms of tumor burden. She had a fairly small tumor and a nearly normal sized brainstem, but the tumor that was present in her left cerebral peduncle caused her to have a pretty dramatic right hemiparesis, right in her corticospinal tract. And this T2 abnormality here was very symptomatic. That is the region of the tumor that responded best to her infusion and largely resolved. Together with that improvement in the tumor burden in the corticospinal tract, she regained use of her right hand, which had previously been held just in flexion, it was very spastic and held in flexion. She regained the ability to move her fingers, to use the hand in play. Her right leg also improved with more normal tone, much better motor control. So marked improvement in right-sided spasticity and weakness of both the arm and leg. Her balance also improved. Her coordination improved. She began to learn to ride a scooter using her right leg to kick off, which was great. She had had chronic nausea since the time of diagnosis. And that resolved because of involvement of the area postrema in the brainstem. She started to eat really well and she had a big growth spurt. She grew 5 centimeters in 1 month. She skipped 2 growth curves in weight. Her drooling and hypophonia also improved, but there was new disease evident in the cerebellum by 3 months and that began to grow. So her response was mixed. We gave her subsequent infusions, which further improved the brainstem disease and her right motor function, but she continued to have disease progression in the cerebellum, and she died from that. showing this kind of mixed response. Here in the cerebral peduncle, you see that the tumor volume, initially by 2 weeks, it looks like it's increasing. This is pseudoprogression as there's, tumor-associated inflammation. And then it begins to decrease, and that cerebral peduncle disease in the midbrain in the corticospinal tracts remain decreased throughout the rest of her life. However, the cerebellar disease, shown here in pink, just increases over time. And we think that this heterogeneous response, this mixed response in different regions of the tumor and different regions of the nervous system, reflects different microenvironments. So the first patient with a spinal cord DMG that we treated was a 25-year-old medical student with an H3K27M mutant spinal cord diffuse midline glioma. This was centered at T10. She had surgery, standard cord radiation, and then enrolled on the trial. Unfortunately, she progressed so rapidly while we were making the cells after enrolling her that she became nearly completely paraplegic and also exhibited tumor spread to her brain, to the medial temporal lobe. We took her off trial and sought compassionate use in EIND for use of her cells off trial. We performed an urgent duroplasty to decompress the spinal cord, given how large it had grown, and then treated her on compassionate use. She had grade 3 CRS. She had fever and hypotension requiring 1 pressor, but otherwise tolerated the first administration very well. She, as I'll show you in a moment, had a dramatic response in her spinal cord and no response in the brain. The cord response resulted in regaining some motor function. She went from really being completely paralyzed, unable to do more than wiggle 1 toe, to with harness support, walking on a treadmill in physical therapy. She also regained urinary continence. But unfortunately, as was becoming a pattern, she progressed at 2 to 3 months and then came back to us for retreatment. This is her spinal cord disease. I'll highlight the tumor here. At baseline, it's quite large, and then it rapidly decreases. And then by about 2 to 3 months begins to grow again. We treated her again and saw a subsequent decrease. The first time we treated her, her spinal cord tumor reduced by greater than 90%, the second time greater than 80%. But, if we had known that it was going to grow as quickly as it did, we would have retreated her sooner. And that became a principle that guided our subsequent therapy for the next patients. Here's the change in volume of the tumor over time. Unfortunately, this disease that spread to her medial temporal lobe just continued to grow. Before we treated her the second time, she had a medial temporal lobe resection. We were very worried about swelling in this particular location and the potential for uncal herniation. The tumor that was resected, we were able to examine for GD2 expression, wondering if perhaps it did not respond because it didn't express the antigen. But actually, we saw very high GD2 levels in the tumor. So this is a tumor with the antigen present, but that did not respond to therapy. So what can we learn, from the correlative studies? What determines a patient who responds versus doesn't respond? What's happening as the tumor progresses and we lose CAR T-cell efficacy, between 2 and 3 months? Fortunately, we did have this access to the cerebrospinal fluid and routinely drew samples for cytokine analyses, for single cell RNA sequencing, for cell-free DNA. In the peripheral blood, we found that CAR T cells, did persist. They persisted, pretty well through a month and through 2 months, and then we began to lose persistence. We had the worst persistence in our little 5-year-old and really lost evident CAR T cell presence in her peripheral blood anyway during the first month. After intracerebroventricular administration, we actually saw even expansion and persistence in the blood from the patient with the spinal cord disease, and also detectable CAR T cells from DIPG patient number 2. When we look at the CSF, we can find the CAR T cells in the CSF, particularly at the points of peak inflammation. So day 14 after IV administration, day 2 to 3 after intracerebroventricular administration. The inflammatory cytokine and chemokine profiles were, prominent but different between comparing IV to ICV administration. After IV administration, we see elevated pro-inflammatory cytokines in the blood in all patients, in the CSF as well, in all patients. In the CSF, though, after intracerebroventricular administration, pro-inflammatory cytokine expression is much higher, whereas blood cytokine expression is much lower compared to IV. And we saw much higher grade cytokine release syndrome in general after IV administration than after ICV administration. So one difference, we have one patient who has had no real therapeutic response and 3 patients who had at least a temporary benefit. The first DIPG patient who had no therapeutic response had really high anti-inflammatory cytokines in the CSF. We saw, very prominent expression of all of the TGF-betas in this patient, much less so in the DIPG patients who had a better therapeutic response. Single cell sequencing starts to show us some differences both in this CAR T cell product between patients and in the cells that we can identify in the CSF. Chiefly in the CSF, we saw lymphocytes and myeloid cells. Looking at differences that might inform this therapeutic heterogeneity, when we compare DIPG patient 1, who had no response, to DIPG patient 2, who had, temporary but really prominent therapeutic response, we see that there's, some important changes in gene expression that chiefly indicate that, in the first patient, when we're just looking at the CAR T cell product, that those CAR T cells in DIPG patient 1 were a little more just activated and revved up to begin with, which might suggest that those initial CAR T cells were more prone to exhaustion in patient 1 compared to patient 2. Looking at the myeloid cells in the patient's CSF was really informative. Number one, and I don't think we would have expected this necessarily, we see a much greater proportion of immune activating myeloid cells after intracerebroventricular administration than after IV administration. So the myeloid cells are more favorable, surprisingly, after direct into the brain administration compared to IV. We see that there are more immune suppressive myeloid subpopulations or immune-derived suppressor cells at late time points after ICV administration and in general after IV administration. We also see more Tregs after IV administration in the CSF than after intracerebroventricular administration. So again, a much more immune suppressive cell types being detected after IV compared to ICV. And the myeloid cells between patients also, highlight important differences as well as between administration routes. So comparing patient 1 to patient 2, we see a more myeloid suppressor cell phenotype in patient 1 compared to patient 2. We similarly see a more suppressive phenotype in DIPG patient 2 after IV compared to ICV administration. So the clinical trial is ongoing, and in the next 10 minutes, I'll let you know how things are going now. To date, on this first arm of IV administration followed by ICV administration, we've treated 12 patients. 4 were treated on dose level 1, 8 were treated on dose level 2. Of these first 12 patients, 10 have exhibited clear radiographic and clinical improvement, and 2 have not. And the correlative studies are beginning to elucidate mechanisms that may modulate the response and that we may be able to target to optimize the therapy. In terms of the neurotoxicity that we've seen, it has been manageable with anakinra, CSF drainage, and sometimes glucocorticoids. In terms of the kinds of neurotoxicity that we see, it's really difficult to grade and attribute the kind of toxicity that we see because of tumor inflammation-associated neurotoxicity using the current CTCAE grading scale. And so we're working within a consensus group to develop a grading scale for this entity of tumor inflammation-associated neurotoxicity. But using CTCAE, we saw definitely saw hydrocephalus exactly as we predicted in several patients. We've been able to manage that safely because we had the OMIA in place. In only one patient did we see ICANS. It was that patient with the spinal cord glioma that received the intracerebroventricular administration on compassionate use. That was a patient at the time that essentially had gliomatosis cerebri by the time we treated her. So it was difficult to determine ICANS versus just on tumor on target inflammation. We have not seen much ICANS otherwise, in contrast to what we see in our hematological malignancy patient population. The frequent ICV dosing that we started to incorporate on dose level 2, informed by what we learned from our patients on dose level 1, has resulted in some sustained clinical responses and benefit, and I'll tell you about these patients. Radiographically, this is the sort of best response for each of the patients treated on trial. The clinical response doesn't necessarily correlate with the radiographic response. So, this patient here with a minor radiographic response has had a really marked and important clinical response. And I'll tell you a little bit about that patient. We do have one patient who has had a complete response, which I almost can't believe that I'm saying. It's just unbelievable in this disease, and makes me so hopeful that this is a therapy that we'll be able to optimize. Using the Raynaud criteria, which is flawed in many ways for these diffusely intrinsic gliomas. Again, we have one complete response, 2 partial responses, and many minor responses. The duration has, when we give the therapy every 1 to 2 months, we've seen some really nice sustained responses, 14 months, 1 year. Many of the patients are still on therapy. So this is a patient with DIPG who was 17 at the time of diagnosis. He has achieved a complete response over the course of 6 infusions administered over the course of a year. And he went clinically from needing assistance for walking to walking independently. He's had return of sensation to his face and body. His hearing, which he had lost on one side, on the left, has come back. And this is his tumor. This is a little bit of an unusual appearing DIPG. There's this large nodular component and then the more classic diffuse infiltrative component. And I'll show you more pictures of this case at different levels. But here in the pons, you see that very quickly this large nodule started to disappear. The diffusely infiltrative component also began to disappear. This is the biopsy tract, and there was clearly tumor around the biopsy tract. Again, here's his biopsy tract again. The biopsy tract now remains, but there really is no evident change or tumor in or around it. Looking at that same patient, because I love looking at this case right now, it's really just so incredibly hopeful. At the different levels, I just showed you here this row showing the change in the pons. In the medulla, you see the medulla diffusely infiltrated by tumor here. That begins to resolve. There's a little bit of a smudge that looks like it's likely tumor, that small area of T2 abnormality, which is present at 5 months, but then has essentially resolved. In the midbrain, here he has an enlarged midbrain with obvious T2 abnormality that normalizes quickly and remains normalized. And he's doing excellently clinically. He just went to his prom and got into his first choice of college. So fingers crossed that we continue to see this response. We are continuing to treat him every 2 months. We also saw a really marked near complete response in a 30-year-old with a spinal cord diffuse midline glioma. She's received 7 infusions and her tumor decreased markedly. She also regained the ability to walk with a cane and regain continence of bowel and bladder. This, at the moment, is beginning to grow again, though. This is the child that is now 5. She was 4 when we began to treat her. And she's had this sustained clinical and radiographic improvement for about 14 months, but it's not nearly as impressive as the images that I just showed you. This was her baseline MRI scan, and you see this just classical appearing, diffusely infiltrated, just a bit too big, a bit too bright pons with this sort of heaping and engulfment of the basilar artery. You see that here, 1 year later, there's a little bit more CSF that you can see around the pons. The fourth ventricle is more open. The pons looks a little bit darker. It's clearly a bit smaller, 10% or so smaller. But she's had sustained clinical improvement. Her 6th nerve palsy, although not completely resolved, is much better. She went from not walking to running and actually rock climbing. Her baseline facial diplegia has resolved. She now has a large, wide smile. Her baseline hypophonia and dysarthria has improved. And I just want to show you this as a, as a neurologist, her coloring, some of the improvement is difficult to grade and to quantify, but you can see before her first infusion, this was her fine motor control and her coloring. By the first week, we started to see some improvement. And by week 4, she went from, this to coloring very, very clearly, and beautifully within the lines and with excellent fine motor control. And we're starting to incorporate now in the trial patient-reported outcomes, because it is hard to capture in traditional ways these kinds of quotes. And I'll let you read this quote from her mother, and compiled from multiple notes she sent us about how excited she is about how well she's doing. Here are the survival curves. I think it's too early to draw much in the way of conclusions. Clearly, the first group of patients that we treated early in this clinical trial, enrolling them at 13 months. These were already not typical cases of DIPG, because the median survival is only 10 months. These were people who lived long enough and did well enough to learn about the trial and get on the trial when it opened. The median survival for that first cohort was 20 months. I think the second, dose level, we were able to enroll patients much earlier, typically right after radiation, often before the time of progression. So median enrollment time was 5 months after diagnosis. Right now, 4 of the first 8 patients are still alive and doing well, and median survival so far is 18 months. But we need to do better, and we need to optimize this approach. And so in the last 2 minutes, leaving some time for questions at the end, I want to just say that we're continuing to learn from the correlatives. We've sequenced from dose level 2 patients 500,000 cells. We are already beginning to see again this pattern of myeloid-derived suppressor cells correlating with limitations to response. And so we've gone from the bedside back to the bench, and this is some unpublished work showing that if we target this myeloid population, we actually can increase the efficacy of the CAR T cell therapy for DIPG. So this experimental paradigm is that we xenograft patient-derived DIPG cells into the pons in young mice, allow them to engraft, and then treat with CAR T cells at a dose that is insufficient to clear the tumor. And what we find is that if we treat, with either mock CAR T cells or this low dose CAR T cell, the tumors continue to grow. But if during this time period we deplete myeloid cells using a CSF1R inhibitor, then when we give this low dose CAR T cell, it is markedly efficacious and resolves these tumors. We've now repeated this multiple times. We don't know yet if the CSF1R inhibitor is safe to give in this context, and we're looking at that, particularly concerned about the potential rate of intratumoral hemorrhage, which is very common in these diseases in the mice. But it makes the point that the myeloid-derived suppressor cells are as hypothesized, modulating this response and represent a way that we might be able to optimize this therapy, either depleting them or modulating them through another means. So in conclusion, the lessons that we've learned so far: Safety, as predicted, requires a closely monitored inpatient setting. This is not the kind of therapy that can be given on an outpatient basis. It also requires a multidisciplinary approach that applies principles of neurocritical care management. The CAR T cells so far have induced on-target, on-tumor inflammation. And this was a real concern in starting the trial because of the low level of GD2 that's expressed in normal brain. We have not seen any off-tumor toxicity. The repeated dosing is both tolerated and also promising. And this was also a surprise because repeated dosing of CAR T cells in hematological malignancies has just not shown much efficacy. But in the central nervous system, and consistent with the experience reported out of City of Hope, et cetera, this repeated dosing is both tolerated and seems to work pretty well. Because we've determined that the ICV administration is better tolerated than IV administration, both from neurological as well as importantly cytokine release standpoints, we're now beginning an ICV only arm of the trial, arm B, where we don't give lymphodepleting chemotherapy and we just start administering the therapy intracerebroventricularly. In general, and I just find this enormously hopeful, the neurological deficits of these diffusely infiltrative gliomas are reversible with effective therapy. And really that fits, and if you come to my next talk at 4 o'clock, you'll see why, that this tumor chiefly is inducing neural circuit dysfunction, but not destruction. This is a cancer that integrates into neural circuits and depends upon neuronal activity to grow. And now we see that if we can specifically disintegrate this cancer, if we can pluck it out with an effective immunotherapy, that those neural circuits can work again. And I find that enormously hopeful. But a durable response in all patients is going to require a much deeper understanding of the tumor microenvironment and the ability to target it therapeutically. Many people to thank. This was truly a team effort. I want to especially shout out Mariella Philbin there at Dana Farber for helping us with our single cell analyses. And of course, the patients and families who have participated in this trial. Hopefully we saved a couple of minutes left for questions.
Okay, thank you for this very impressive and very promising therapy presentation. So we have a number of questions here. Let me try to look at it. So one question related, actually 2 questions related to the expression of GD2, D2, the target. Yeah. So one of them is that how the standard therapy influences the expression and also the responders or progressing cases. Do you see a change in expression? Or my question would be, do you see heterogeneity in expression? Right.
So it's a very good question whether GD2 expression can be influenced by standard therapies. There's something that we're testing right now is whether radiation might upregulate GD2. There's also work being done to look at epigenetic modifying agents to see if they influence GD2 expression. Whenever we've had the opportunity to look histologically, we've seen high uniform GD2 expression, even in the context of therapeutic failure. It doesn't seem yet to be a case of antigen loss or antigen heterogeneity. What we see being much more heterogeneous is the presence of the myeloid cells and the density of those myeloid cells. Mm-hmm.
Yeah, so a question related to that, if you CSF1R treatment, do you think the macrophages are there just to remove the CAR T cells or the dead cells, or are they really blocking the function of CAR T cells?
So I don't have evidence, but I suspect it's both. I think we'll find as we dig deeper that some of the anti-inflammatory cytokines are coming from the suppressor cells, whether there's a checkpoint inhibitor, a checkpoint function inhibiting T cell efficacy from the suppressor cells is a question. And then certainly I think they're phagocytosing the CAR T cells. We saw in the single cell data evidence of lineage doublets, myeloid plus lymphocyte, and we suspect that those were phagocytosed T cells.
Okay, and then one more question related to, do you think patients will benefit more from application of tumor targeting proton beam therapy to diminish the tumor burden before applying the CAR T cell immunotherapies.
Yeah,
so that would,
radiation, yeah, sorry.
Yeah.
Radiation is a very, I'm not going to comment on proton versus photon, but radiation is the gold standard. Everybody receives standard radiation before enrolling on the study. It's required. We allow for reirradiation in between cycles. None of the patients I just showed you had that, but that's something that we have allowed for, because sometimes there are, regions of a tumor or a new site of spread that had not been previously irradiated that begins to grow, and we need to sort of gain local control over that. And there's also the theoretical benefit that radiation might be modulating this microenvironment. We know that radiation induces dramatic changes in the resident myeloid populations. So many questions, I think, open about how to best leverage radiation and reirradiation in this context, but it is an important tool, and we have so few tools in our toolbox for this disease. When the disease begins to progress, reirradiating is something we should be considering.
Yeah, and just one last question that I'm curious. Like the GD2 function could also be influenced by metabolic state, and particular lipid or other metabolism. Could that be potentially helpful to get better responses? Some combination therapy.
So I think that there are going to almost certainly be opportunities for combination therapy, metabolic therapies, or both to influence GD2 expression, although we don't seem to have, that doesn't seem to be the problem. We seem to have really high GD2 expression. What we have is very altered and heterogeneous other cells present. I think, targets of the tumor, other targets in the tumor microenvironment, the myeloid cells, but also the neuron glial interactions, which I'll talk about later, are going to be really important. There's a question about the timing of CRS and whether this is due to a delay in target engagement. Yes, we absolutely think that's right. So we see CRS after 1 million cells per kilogram at day 6 to 7. After 3 million cells per kilogram at dose level 2, we very consistently saw CRS at day 3 rather than day 6 to 7. And when we give CAR T cells intracerebroventricularly, we see the fever happen within 12 hours. So I do think it's about when the cells find the tumor.
Okay, thank you so much for this excellent presentation. And again, everybody, it's recorded, so you can look back on the website, and hopefully some of those patients will continue to do well and have response. And looking forward to your talk at 4 o'clock today.
Thank you.
Okay.
All right. Thank you so much for the great questions.
Thanks. Bye. Bye-bye.